tardes. Vamos, todavía quedan personas por entrar, pero
Recording
bueno,
in progress.
vamos a ir empezando esta sesión para no retrasarnos. Quiero decir que, ahora aprovechando que están aquí los ponentes, que va a haber un bus al final de la sesión para llevarlos al hotel. O sea que it's going to be a transport for the hotel at the end of the session, okay? Sí, bueno, esta mesa es de enfermedad hepática metabólica y nuestro primer invitado es el profesor Laurent Castera, que es profesor de medicina y departamento de hepatología de la Universidad de París y también está en el hepatólogo del hospital Vosjon en Clichy. Es un experto de primer orden internacional en marcadores no invasivos de la enfermedad hepática crónica. Muchas gracias, Laurent. Thank you very much for coming.
Okay, thank you. Good afternoon, everyone. Thank you, Raoul, for the kind invitation and for this distinguished audience with the best expert in DILI worldwide. So I will not deal with DILI, but with MASLD, that is much more common. Okay, just want to draw your attention to introduce the subject. This is a paper that just appeared last week on the big consortium that some of you probably participated, the Liver Screen Consortium that has been ongoing for almost 10 years. And what we have done is screening 30,000 people in the general population using liver stiffness FibroScan with the 8 kilopascal cutoff. And the message is undiagnosed liver fibrosis is common in the general population in Europe and primarily driven by metabolic factor and alcohol consumption. And early detection is pivotal, of course, as it could allow personalized intervention that can prevent progression to cirrhosis and complication. And this involved 9 European countries. And in a nutshell, this is one of the messages. You can see there is the increase in the probability of having significant fibrosis according to the number of metabolic conditions. But if you add alcohol, you go basically from 2% to almost 40% in the general population. So this is the magnitude. A subset of patients underwent a liver biopsy because they were referred to an expert center, less than 500. And no surprise, the most common cause of liver disease was steatotic liver disease, and mostly MASLD, a few MET-ALD, NALD, and other etiology. Okay, now let's go back to the subject. These are the relevant questions in practice in MASLD patient. Does the patient have advanced fibrosis? Is the patient at risk of developing outcomes? You know MASLD natural history, and MASH is a turning point. If you lose weight, if you improve, then you might have regression. If you worsen, then you will develop more fibrosis and cirrhosis. And clearly, mortality is associated not with MASH, but with liver fibrosis severity, not only liver-related mortality, but also all-cause mortality. And the challenge actually in clinical practice is really to be able to spot the subset of patients among a large bulk of patients, and this is really like finding a needle in a haystack. Unfortunately, transaminases that have been used by clinicians for decades are not very accurate to capture MASH and fibrosis severity. Same can be told regarding the usual liver test And you can see that sensitivity is way too low, again, to capture cirrhosis in this population. So the interesting thing is over time, we started with clinical diagnosis, and most patients were diagnosed at the time of decompensation, and this is still the case, again, currently in the majority of patients. They come with the usual ascites or variceal hemorrhage. With the advent of liver biopsy in the late 50s, of course, you could capture more and define, but this is clearly a bottleneck now given the magnitude of the problem to capture fibrosis in a large population. So you know all the limitations of liver biopsy, but if you want to tackle this epidemic, if you look at the number of hepatologists in Europe, it's less than 6,000. And the very high number of patients, 135 million in Europe, 1/3 of the global population in Europe. So fortunately, we have non-invasive tests. This happened now almost 20 years ago. And the most popular one are FIB4, ELF for the blood test, VCT, better known as FibroScan, and MRE for measuring liver stiffness. I want to stress that it may seem very simple and trivial, but it's really important in your practice to take into account cost, availability, and most importantly, context of use. So let me illustrate. For instance, FIB4 is widely available and comes with no cost. MRE is not widely available and it's highly costly, mainly for research purposes. Now, context of use is even more important. Most of these NITs have been developed in liver clinic. And if you look at the NPV and the PPV, among the three most popular tests, the NPV is fine, but look at the PPV. It goes from 50 to 76%. So you end up with a lot of false positive. This is in the liver clinic. Now, if you go to primary care, there's really an issue with the remote. I'm sorry, I have a lot of animation, so I'm stuck with the... Thanks. So in primary care, the probability of advanced fibrosis is much lower, below 10%, whereas it's above 30% in our centers. And you look at NPV is fine, it's even better, but the PPV is very, very poor. So you cannot rely on a single test. And the way to go is like screening for colorectal cancer. You start with a very simple test, widely available, high NPV, high sensitivity. So it's like the FIT test. And then you need a second test in the intermediate population, better PPV and better specificity. And this is either elastography or ELF. So this is the way to go. Sequential algorithm. This is for screening advanced fibrosis in the general population. And just to make a long story short, you can see that we have many guidelines aligned above both sides of the Atlantic, and AGA, ASLD, AAC, ADA, EASL, of course, ESD. So that's a good sign, and this is the way to go. This is the latest algorithm sequential from EASL, ESD, ESO. I don't have time to go into detail, but I want to emphasize that if we stick to this loop, we're not going to be able to make it. It's very confusing for non-experts. Of course, you're all liver experts, and that's one of the issues of the guidelines. When I give talk to GP, they have no clue about our guidelines. They have no clue about NITs. They have no clue about MASLD. So you must come with a very simple message if you want them to adopt a strategy. And this is not going to work, I can tell you, because if you have dual cutoff, it's not the way to go. Don't forget that for the 2.65 or 67, you will just capture less than 3% of the population. 3%. Is it worth having two cutoff for 3%? Because this is what the NN study shows in the general population. So I think you need to simplify screening and come up with a very simple message. Basically, if the FIB4 is below 1.3 or 2.0 if you're above 65, done. You don't need a second test. They might stay in primary care. If you're above 1.3, then you need a second test. And there's three possibilities. If VCTE is above 8 kilopascal, so liver stiffness, advanced fibrosis is unlikely. You don't need to refer the patients. You're back to the previous page. If you're above 8 kilopascal, advanced fibrosis is suspected. Suspected doesn't mean likely. Then you need a second test. If you're above 12 kilopascal, advanced fibrosis is likely. And then you may go to the liver or gastro clinic and consider surveillance for HCC. This we can discuss. Confirmatory testing may not be needed in that case. Okay, I just want to take, I know we are a little bit behind the time, a few minutes to discuss about type 2 diabetes, because this is really where the field is going. And just to remind you that patients with type 2 diabetes are mildly is more frequent as more severe. This is exemplified in this very large meta-analysis. More than 60% of type 2 diabetes have MASLD, but they are not screened for. And severity also is higher. And this is exemplified in the study that we've done in France, the so-called Quid-Nash study. So what we have done, instead of waiting for the diabetologist to refer patients, which I can tell you will never happen, we establish a liver clinic in the diabetes clinic. Because in the diabetes clinic, what they do, they check for the eye, they check for the kidney, they check for the heart, they check for everything but the liver. So we decided to go there and to see their patients, all comer. And look what we have done. We've been crazy enough to propose a liver biopsy in people with ALT above 20 in female, 30 in male. Most people, including in this audience, would think this is normal. But it's not normal. As a result, to make a long story short, you can see we perform liver biopsy in more than 300 patients with type 2 diabetes, and you end up with 2/3 having NASH or MASH, and 1/3 having advanced fibrosis. These are all comers, unaware of having liver disease. You have 1/3 of them that would qualify for treatment and also for screening for HCC. So there's a very large reservoir of patients in the type 2 diabetes clinic. I do not claim this is epidemiology. I just claim, and I don't want to perform liver biopsy in all these patients. I just want to make the point, there's a reservoir of undiagnosed patients to be treated. This has been confirmed in another study from the US by Rohit Lumba with a different methodology, but basically you can see that in the American population you have the same numbers. Now let's see how it works in practice to implement the algorithm. This is very important because there is confusion between the disease type 2 diabetes and the context of use. In France, and probably the same in Spain, 85% of type 2 diabetes patients are followed by primary care physicians. They've never seen a specialist. And around 10 to 15% are in the diabetes clinic. So the context of use is different. So this is the NN study, and you can see if you're applying the algorithm, you will end up with a referral in around 5% of the patients. Now, this is a study from France. So in the diabetes clinic, screening for advanced fibrosis, again, to make a long story short, you end up with almost 18% needing for referral. But you're looking at the same disease from a different angle. And there's a bias selection toward more severe patients. This is our experience in our diabetes clinic, so real-world diabetes clinic, comparison of all pathway. Again, you around 12% that need referral, so higher than in primary care. More false positive than false negative, which is expected. but looked at the EASL algorithm in this population, so 1,500. But 70% would not qualify for a second exam. But if you perform liver stiffness in these patients, you end up with 19% false negative. So you're missing almost 20% of your patients because of FIB4. Now, if you start with VCTE as first line, you will increase the referral rate from 12 to 19%, and you decrease the false negative. So in other words, the way to go in this population, of course, they are more severe. They're like the patients we are seeing in our clinic. You start with a FibroScan first. FIB4, there's a risk of false negative. So these are my summary. Sequential algorithm with, 6 is not 5, international guideline ally. Single cutoff for FIB4, dual cutoff for FibroScan. And we can deal with dual cutoff as specialists, but the GP cannot. It's critical to screen for patients with type 2 diabetes. Primary care, you use the same FIB4 VCTE, and maybe, because we need more data, of course, and external validation, VCTE as first line in diabetes clinic. Okay, let's move for the 5 remaining minutes for developing outcome. We are now at a stage where we have nice meta-analysis from the litmus showing that basically FIB4 predict clinical outcome as well as liver biopsy. One of the issues with FIB4 is age is part of the formula. So this is a major confounding factor. ELF also has prognostic value in MASH cirrhosis, and look at the median follow-up, short, 15 months, and these are clinical trials. This is not real life. Now, meta-analysis with VCTE showing the same. You can see there's no difference between liver biopsy and liver stiffness, baseline liver stiffness for predicting outcome. This is a recent study that we have done with Vincent Wong, and this is real life in a smaller cohort, but showing very similar result. So validating the meta-analysis result. Now, this is what it looks. We have 2 now large study, one from mostly Asia, from Vincent Wong. You can see large set of patients, 16,000, with several measurements. And you can see that you can stratify your population according to 10 and 15 kilopascal cutoff in terms of occurrence of liver-related event. This is another cohort from the US, from the NASH CRN, smaller cohort, but prospective, with a FibroScan every year for 4 years, and you end up with very similar results. So that's quite reassuring that in different populations you're saying the same. And actually, again, in a nutshell, I think what you should take back home as a simple message for your clinic is that 10 kilopascal is a turning point. Below 10, nothing is going to happen. Above 10, then there's an incremental risk of having liver-related events. But, so, in other words, if you're going above 10, you're more likely to develop liver-related events. If you're going below, you're less likely. But let me take an example. If you go from 9.9 to 10.1, do you consider this is clinically relevant? Of course not, because there is variability with the technique. And the quality criteria are around 30% to control the variability. So you need a composite endpoint. Relative increase or decrease, and also different cutoff. So let's go into that. Liver stiffness is a continuum, and we know that, and this is what Baveno has proposed with a rule of 5 for portal hypertension. Now, the next rule, especially for the next trial coming in cirrhotic patients, you need to stratify your population according to portal hypertension, which most people in the MASLD field ignore, actually. Because if you look at the initial trials, they were not stratified according to portal hypertension. And the idea was that in 1 year, people would regress their cirrhosis with a fantastic treatment. And of course, this did not happen. but it was just an error in design. I mean, you need longer time and you need to stratify your population. The issue with that, we know again that liver stiffness above 25 kilopascal is good in every disease or almost every disease, but not in obese MASLD. Because you can see there's a lot of false positive. So what has been proposed is a so-called anticipate NASH model that combine liver stiffness, platelet count, and then BMI because the anticipate model has been proposed around 10 years ago. Just to illustrate, same liver stiffness, same platelet count, but the BMI is going to make the difference, and you will not overinterpret the prevalence. Very recent data also from the people from portal hypertension showing that this model has better discrimination for liver-related event than histology. So this is going to be used now. The stratification in the forthcoming trial will be done on invasive test. Last but not least, of course, in practice, you don't perform a single measurement. This was baseline. You repeat over time, and this is the way where everyone is going, repeating. This was the first study by Salvo Peta 5 years ago, showing that not only liver-related event, but mortality and overall mortality also could be better predicted with more granularity if you use changes over time. The cutoff 20-30% is debated, but let me just take 2 minutes to comment this study that is a very important study. Again, the study from Vincent Wong. So 10,000 NAFLD patients with 2 VCTs. This is a spline curve. And what you can see, if you have an increase of 30% from baseline on the second measurement, the risk increased by 20%. This is already known. What we didn't know before is whether if you decrease the likelihood of having liver-related events. This has to be shown. And this is exemplified in the study. You decrease by 40%. So this is a proof of concept. Now the way to use it, you stratify your patient with your first liver stiffness measurement. We start with 10 kilopascal. And you see if you have a decrease or stable or an increase, nothing happened. Basically, you go from 1.4 to 2.4. So it's pretty stable. If you're in the intermediate category, 10 to 15, so the Kakeldy definition according to Baveno, there you can see a change. You go from 1 to 17 if you decrease or if you increase. And if you're above 15, you can see that it's even more marked. So the way to go is stratify at baseline, so risk category like I mentioned for 10, and then you use a composite endpoint with a 30% increase or decrease. These are summary and conclusion. So NITs are useful for risk stratification in MASLD patient with Kakeldy. 10 kilopascal seems a turning point. The next step is repeated measurement, and percentage of clinically relevant LSM increase remains to be agreed upon. Thank you very much for your attention.
Thank you, Laurent.
I'm sorry I went a little bit over time.
No. It's okay. We have a few minutes for discussion. Xavi?
And then you said these are better tested with FibroScan. My question is, it's still a big number of patients. I know that the risk of missing them with FIB4 is clear, you made the point, but since your study has a large cohort, are there other variables that can identify those patients at higher risk of having advanced liver fibrosis, for instance, BMI, age, time of diabetes? Because I think this is relevant in case you have 1,500 patients in the diabetes clinics. Thank you.
Okay, this is a very good point. For the sake of time, I did not show all the data. Initially, when we did that, this was like 5 years ago. So most diabetes clinics did not have FibroScan. So we wanted to have a very simple score that could be used on the next Monday in the clinic. And basically, I mean, you come up with, you're right, age, BMI or waist circumference, GGT, and cholesterol. And if you combine them, you could predict, not as well as soon as you introduce liver stiffness, everything disappears. But still, if you don't have a FibroScan, and this is still the case in most diabetes clinic, you can use it. And also it's a leverage to raise the awareness of our diabetes colleague. Awareness is increasing, but still, I remember when we arrived in this clinic, they were very skeptical. They were telling us, we've never seen a cirrhosis. We've never seen HCC. Of course, they come to our department. They do not come to your department. And then when you come up with a liver biopsy showing them the proof, you've been following this patient for 10 years and she has cirrhosis. Wow. Then they started to get convinced. And now they became ambassador in the diabetes community saying, you need to screen your patient. And it's very easy to implement, you know. These patients come once or twice a year for the annual checkup. You just implement a FibroScan and you screen them. A lot of them will be below 8, but as soon as they're over, of course, they need to have another test.
Okay, thank you. Einar?
Very nice presentation. Thank you very much. I just wonder about the role of PET in these studies. In the Lancet study you quoted first, in the paper, only 59% of people said that they drank alcohol.
Right.
And how do you know that they have muscle D and not metal if you don't have a PET test?
So this study was started in 2018, and the PET was not really popular at that time. Actually, I didn't show the detail, but you're right. There are some people with MET-ALD and a few people with ALD. Actually, the proportion of patients with excessive alcohol intake was 6%. But we're going to do it, of course, based on audit and the clinical impression, which is not that bad. But of course, I mean, experienced clinicians know how to. But you're right. And there's biobanking, of course, in this cohort, and this is something that's going to be implemented. But to your point, no, PET, absolutely. And just for the audience, including in the MASH trial, the highly selected patients, you end up, when you start to implement PET, to find 5 to 20% of patients that are actually MET-ALD rather than pure MASLD.
Yes.
Sub-analysis from cohort, and they did analyze the PET in those patients, and the proportions were quite similar to the rest of the overall cohort in liver screen. So even though we still need to look at the biobank and so on, in the sub-analysis of the Danish cohort, the PET showed that the overall findings were more or less sensible to the differentiation between ALD and MASLD, with the MET-ALD in the middle.
Yes. Yes. Okay.
A quick question. You started with how GPs can't really handle complexity and don't really kind of diagnose enough NASH and all that. So diabetologists are similar.
They can,
Yeah.
but they're over busy with dealing with diabetes,
sure.
hypertension, everything. Liver is not in the radar.
Yeah.
But if we are able to raise their awareness, of course they will be able to do it.
Yeah. More important question is practicality. So diabetologists probably can handle complexity, but don't still care. You had this kind of, John pre-society guidance. Do you feel it has made any difference? Because I have spoken to Naveed Sattar, who writes in our journals, who just simply cannot see any actions to take other than starting statins, so it doesn't really make a big difference for him to diagnose it or stratify it.
Okay, there's two elements of response to your question. First, the first guidelines that were implemented in 2016, I can tell you because I was in charge of ISOL at that time. It took 1 year. It was supposed to be launched in 2015 because the diabetologists did not agree on a figure in the guidelines saying that you must screen diabetes for type 2 diabetic patients, for MASLD. So there was a lot of reluctance at that time. 10 years later, they all agree that you have to do it. First. Second element, with the coming drugs, and especially semaglutide, it's changed their practice. So it's changed their practice. I can tell you what my diabetologists are doing. They increase the dosage of semaglutide. Instead of 1 milligram, it's 2.4 milligram when they know there is NASH. And then they screen for HCC, which makes a difference. So you just need to convince them that it's going to change the management of their patients. This is where you make the difference.
I'll talk to you later about
semaglutide
and the impact of NASH in UK population.
No, but it's just starting. It's been approved. I mean, it's not approved in the UK to my knowledge. So,
I mean, if you want to really know, they have given 9 years to implement it. By the time half the population of diabetes would have had all the risks and consequences. So it's about practicality, certainly in the UK. Yeah.
okay, at dinner.
Sí. Yes, another quick question. With regard to the inflammation, once the patient is at the hepatology facility, hepatology unit with more than 10 kilopascals of FibroScan, is there any role for inflammation to be a composite biomarker for progression or not?
So, if you look at the pathophysiology, of course, inflammation is important. I mean, fibrosis cannot happen without inflammation.
Yeah.
It's a win in the cell. Otherwise, your body is not moving. But at the end of the day, what kills the patient is not inflammation. It's the result. It's fibrosis. This is why, for practical reason, we're focusing on fibrosis. But I agree with you, and we're still checking the transaminase, and this is what is going to happen for treatment. Response will be checked with ALT, very likely, and probably liver stiffness or another NIT. But inflammation, of course, matters.
Okay. Thank you very much.
Okay.
Thank you.
Thank you very much.
Thank you.
Y ahora la siguiente charla es online, la va a dar el doctor Javier Crespo García, doctor en medicina por la Universidad de Cantabria, profesor de la Facultad de Medicina, ha sido jefe de servicio digestivo del Hospital Universitario Marqués de Valdecilla y presidente de la Sociedad Española de Patología Digestiva hasta hace muy poquito tiempo. Ha destacado su labor como científica dentro del Plan Estratégico Nacional frente a la hepatitis C. Es uno de los promotores de la Corte de Cantabria, de la que ahora ha asumido la dirección del proyecto. Y la charla que nos va a dar se titula Fenotipos especiales, esteatosis hepáticas en las enfermedades inmunomediadas. Pues no sé si lo tenemos ya por aquí.
Muy buenos días a todos los que estáis escuchándome en Málaga, donde para mí es una enorme pena no poder acompañaros, pero no ha podido ser en esta ocasión, que es una ocasión muy especial, ¿no? Pues el 25 aniversario de estas jornadas que organizan Raúl y Maribel desde hace tantos años. Muchas gracias por la invitación y de nuevo disculpas por no estar con vosotros. Bueno, me han encargado un tema, yo creo que es un tema muy bonito, que habla de algunos fenotipos especiales en los pacientes con MASLD, ¿no? Todos sabemos, esta es una diapositiva que hemos visto en muchísimas ocasiones, que la enfermedad hepática por depósito de grasa, hablaré indistintamente de esteatosis hepática metabólica y MASLD, es una enfermedad que se caracteriza por la presencia de grasa en el citoplasma de los hepatocitos y que tienen concomitantemente un trastorno de disfunción metabólica que no voy a referir y que se ven en esta parte derecha de la diapositiva. Además de tener grasa en el hígado y tener esta disfunción metabólica, tienen que tener un consumo de alcohol pequeño, menos de 20 gramos en los hombres y menos de 30 gramos en los hombres y menos de 20 gramos al día en las mujeres, porque en caso contrario el espectro de la enfermedad hepática grasa se ha ampliado con los denominados METABOLIC, aquellos sujetos que tienen grasa, disfunción metabólica y un consumo de alcohol superior a 20 o 30 en mujeres y hombres respectivamente, o enfermedad por consumo de alcohol si tienen más de 50 o 60 gramos respectivamente. Pero más allá de esta definición que hace que tengamos un paraguas cómodo para el diagnóstico de esta enfermedad, sabemos que el MASLD es una enfermedad extraordinariamente compleja o, lo que es lo mismo, extraordinariamente heterogénea. Los factores que hacen que la enfermedad evolucione desde un hígado con poco o ningún depósito de grasa hasta una cirrosis hepática o incluso un hepatocarcinoma son, como veis en esta diapositiva, extraordinariamente variados. Hay factores genéticos, factores metabólicos, factores del exposoma, factores epigenéticos, microbioma, todos ellos juegan un papel importante en unas condiciones más importantes que en otras y hace que esta evolución sea muy diferente. Es tan diferente que algunas personas creemos que en realidad esto no es una enfermedad, sino que es un conjunto de enfermedades, ¿no? Y en algún pequeño trabajo nosotros propusimos cambiar la D de disease por la D de diseases o la D de disease por la D de disorders. Pero bueno, yo creo que no hemos tenido mucho éxito y ha quedado como enfermedad hepática metabólica, aunque yo creo que todos entendemos que la enfermedad que afecta a una persona sarcopénica mayor con enorme fragilidad es bastante diferente a la que afecta a un paciente que tiene un trastorno psicótico, a una persona que vive con obesidad. Y dentro de este espectro tan variado de pacientes o de personas que pueden sufrir la esteatosis hepática metabólica, hoy vamos a hablar de un conjunto que es la esteatosis hepática metabólica en los pacientes con una enfermedad inmunomediada. Bueno, las enfermedades inmunomediadas son también un grupo de enfermedades complejas, frecuentes, porque afectan entre el 3 y el 10% de la población en general. Un grupo, como digo, heterogéneo, que están caracterizados todos ellos porque tienen una respuesta inmune aberrante, dirigida contra componentes propios o frente a estímulos externos que están mal regulados, y que tiene que ver con mecanismos inflamatorios que van que no siempre tienen que ver con la inmunidad innata, sino que a veces tiene que ver con la inmunidad adaptativa. Es decir, trastornos inmunológicos asociados a una vía de la inmunidad adaptativa o a vía de la inmunidad innata. Tienen una serie de características comunes. Suelen empezar pronto en la vida, suelen empezar entre la segunda y la tercera década de la vida, aunque tienen un espectro continuo y pueden aparecer en cualquier momento de la vida. Su patogenia es compleja, es una patogenia mixta que incluye trastornos de susceptibilidad genética y algunos desencadenantes que están basados en el exposoma y fundamentalmente tiene una carga elevada de patrones moleculares asociados a daño o a patógenos. El inicio clínico suele estar asociado a una respuesta inmune exacerbada sostenida en el tiempo. Tienen bajo potencial de resolución espontánea, aunque es cierto que evolucionan en brotes de actividad e inactividad, y tienen múltiples complicaciones sistémicas, y una de las cuales es la enfermedad hepática por depósito de grasa. Pero claro, no es tan este grupo de enfermedades, aquí vemos las más frecuentes: artritis reumatoide, psoriasis, artritis psoriásica, Crohn, colitis ulcerosa, por supuesto, lupus o hidradenitis supurativa. Como digo, enfermedades complejas que tienen este nexo común de una patogenia inflamatoria inmunomediada. Pero claro, la enfermedad hepática que aparece en estos pacientes es una enfermedad hepática cuyo diagnóstico diferencial es complejo, y lo es porque en estos pacientes con enfermedades inmunomediadas la prevalencia de hepatopatías autoinmunes es mayor que en la población general, es decir, la prevalencia de hepatitis autoinmune, colangitis biliar primaria o incluso colangitis esclerosante primaria es mayor que en la población general, como muy bien sabemos, por ejemplo, en los pacientes con colitis ulcerosa. El uso de diferentes fármacos, algunos de ellos hepatotóxicos, hace que el DILI sea más frecuente que en la población general. En algunas ocasiones, como veremos, por ejemplo, en los pacientes con psoriasis, el consumo de alcohol es más elevado. Y finalmente, además, existe un incremento del riesgo de hepatopatías virales y de reactivación de hepatopatías virales motivado por el uso muy frecuente de inmunomoduladores o inmunosupresores que hacen que la probabilidad de tener una recidiva de una hepatitis B, por ejemplo, sea mayor que en la población general. Y en este contexto amplio de pacientes que tienen una enfermedad inmunomediada, tenemos que determinar cuál es la probabilidad, cuál es la prevalencia de esteatosis hepática meta. La primera enfermedad de la que vamos a hablar es de la psoriasis, probablemente es la enfermedad en la que existe un conocimiento más amplio de la relación entre esta enfermedad y la esteatosis hepática metabólica, pero hay que tener en cuenta que esta enfermedad tiene una carga de manifestaciones extracutáneas y extraarticulares, recordar que la psoriasis y la artritis psoriásica tienen íntima relación, que hace que no podemos olvidar que los pacientes con psoriasis también tienen una enfermedad cardiovascular y una carga de aterosclerosis propia independientemente de MASLD. Con frecuencia son pacientes que viven con obesidad o tienen sobrepeso y hacen que los trastornos metabólicos y la diabetes mellitus sean más frecuentes. Con frecuencia tienen trastornos psiquiátricos o trastornos adaptativos que incrementan el consumo de alcohol. Y todo ello hace que, aunque parece más probable la enfermedad hepática por depósito de grasa, el diagnóstico diferencial siempre sea complejo. Y a pesar de esta complejidad, hace ya bastantes años, casi 20 años, se publicaron las primeras series en las que se demostraron de una forma no totalmente casual, sino de una forma epidemiológica, que en los pacientes con psoriasis la probabilidad de tener en aquel entonces nuestra denominada antigua denominación NAFLD era más frecuente que en los controles, casi el doble. Unos años después, esto fue en el 2009, unos años después, en un estudio, el primer estudio, digamos, sistemático y con pacientes muy bien caracterizados, dado que todos ellos tienen una biopsia hepática, se vieron los mismos datos. En aproximadamente la mitad de los pacientes psoriásicos se detectaba una enfermedad por depósito de grasa hepática. Y nosotros hemos tenido la oportunidad de ver los mismos datos en una serie muy grande de pacientes psoriásicos, más de 1000, en el que vimos dos cosas. Quizás la más importante no es que había un incremento de la esteatosis hepática metabólica en los pacientes con psoriasis, sino que la probabilidad de tener una fibrosis avanzada era mayor en estos pacientes psoriásicos. Es decir, la probabilidad de tener una esteatosis hepática metabólica más avanzada que en la población general era más frecuente en estos pacientes. Y además de ser más frecuente, se relacionaba en grandísima medida, como veis aquí, la ratio, en grandísima medida con la propia enfermedad inmunomediada, con la propia psoriasis. Como veis, con una asociación mucho más fuerte que con el índice de masa corporal, es decir, que con la existencia o no de obesidad, y más fuerte que con otros factores, con otros trastornos metabólicos que no parecía tener un significado claro. Es decir, la propia psoriasis era la que impactaba en el incremento de la prevalencia de la esteatosis hepática metabólica. Y muy recientemente, en un estudio muy bien caracterizado que publican nuestros colegas de reumatología, que se publica en una revista muy importante, en Hepatology, se hace un estudio sistemático de los pacientes con psoriasis para intentar diagnosticar en todos los casos la existencia o no de enfermedad hepática metabólica, y llegan a dos conclusiones muy importantes. Primero, la mitad de los pacientes, más o menos la mitad, 44% de los pacientes, tienen esteatosis hepática metabólica, números iguales que los que hemos visto anteriormente, pero, y es lo más importante, los criterios no invasivos, los criterios que utilizamos habitualmente para el diagnóstico de los pacientes, un FID4 o NAFLD fibrosis score, son mucho menos útiles que en otro tipo de poblaciones y no son capaces de diagnosticar a la mitad de los pacientes. Esto es un aprendizaje muy importante. Y otro aprendizaje muy importante que no mencioné previamente, es que es independiente del uso o no del metotrexato, este famoso y viejo amigo nuestro que tiene una historia muy controvertida de asociación con la fibrosis hepática y que aquí no parece tener. Nosotros estudiamos hace años un grupo de enfermedades inmunomediadas con una carga inflamatoria notablemente alta. Es una enfermedad rara, la hidrosaleritis supurativa, pero como digo, con una carga inflamatoria muy notable. Y lo que vimos es que en la mitad de los pacientes, en casi 3/4 partes de los pacientes, existía una esteatosis hepática metabólica. Aquí se ve muy bien cuando hicimos un estudio controlado, con un grupo de control muy amplio, procedente de nuestra corte ETON, una corte de población general de Cantabria, Valencia y Madrid, y vimos cómo la prevalencia era casi 2 veces más alta en los pacientes con hidrosaleritis supurativa que en la población general. Y nuevamente vimos un dato muy importante. No solo era más alta, sino que la probabilidad de tener una fibrosis avanzada era mayor. Es decir, es más alta la prevalencia y es más grave la enfermedad. Y nuevamente, esta enfermedad no depende de la existencia de factores metabólicos, sino que se asocia fundamentalmente a la propia actividad de la enfermedad. Se asocia a la propia hidrosaleritis supurativa. Por lo tanto, los datos que tenemos que recordar son muy importantes. En hidrosaleritis supurativa, casi 2/3 de los pacientes tienen esteatosis hepática metabólica. Esta esteatosis hepática metabólica es más grave, más avanzada que en los enfermos que no tienen esta enfermedad. Y 3, además, esta esteatosis hepática metabólica depende fundamentalmente de la propia actividad de la enfermedad inmunomediada y no tanto de los trastornos metabólicos asociados. La tercera enfermedad que les voy a mencionar y de la que también tenemos experiencia es la enfermedad inflamatoria intestinal. Hace ya ciertos años, hace no menos de 8 o 10 años, que se conoce la relación entre el desarrollo de esteatosis hepático-metabólica y la enfermedad inflamatoria intestinal, tanto el Crohn como la colitis ulcerosa. Y yo les voy a contar nuestra experiencia, una serie muy amplia, una experiencia compartida con el Hospital Puerta de Hierro, en el que analizamos un número de pacientes muy importantes. Si se fijan aquí, invitamos a participar a 1.600 pacientes con enfermedad inflamatoria intestinal, de los cuales pudimos completar el estudio de función hepática en aproximadamente 1.000 y finalmente incluimos a aproximadamente la mitad de los que habíamos invitado a participar. Un número, como digo, muy importante, 800. De estos más de 800 vimos que, como ven aquí, tenían una enfermedad hepática metabólica casi la mitad, un número muy elevado de ellos, de los que en la inmensa mayoría de los casos no estaba asociado al consumo de alcohol. Es decir, eran más healthy según los criterios, entonces más healthy en la actualidad, más healthy en los criterios actuales. Y los comparamos con un grupo control en el cual la prevalencia de esteatosis hepática metabólica era más baja, es alta, pero más baja, claramente más baja que en la población de enfermedad inflamatoria intestinal, y el consumo de alcohol era aproximadamente el mismo, un poco más bajo en población general que en sujetos con enfermedad inflamatoria intestinal. Por lo tanto, desde un punto de vista epidemiológico, las personas con enfermedad inflamatoria intestinal tienen un incremento de la prevalencia de esteatosis hepática metabólica. Quisimos saber a qué se asociaban esta enfermedad hepática metabólica en los sujetos con enfermedad inflamatoria intestinal. Y bueno, vimos algunas comparaciones que parecerían razonables, y cuando uno está enfermo por las cifras, cuando son tantos enfermos, a veces hay diferencias significativas que tienen poco que ver con las diferencias en la clínica real. Pero sí vimos algunas diferencias muy importantes. Fijaros, en los pacientes que tenían enfermedad inflamatoria intestinal, la probabilidad de tener una fibrosis avanzada, que nosotros definíamos como igual o superior a F2, era mucho más alta en los pacientes con enfermedad inflamatoria intestinal respecto a los controles. Pero cuando de los pacientes con enfermedad inflamatoria intestinal excluíamos a los pacientes obesos, estas diferencias todavía eran más altas. Fijaros que aquí la diferencia es aproximadamente el doble 9,5% sobre 5%. Cuando quitábamos los obesos, la diferencia era casi 5 veces mayor. Si además decíamos que no eran diabéticos, la diferencia era 9 veces mayor. Y en las personas que no eran diabéticas y no obesas, que tenían MAFLD, la prevalencia en pacientes con enfermedad inflamatoria intestinal era casi 15 veces mayor. Es decir, esto nos viene a decir que en los pacientes con enfermedad inflamatoria intestinal, la propia existencia de la enfermedad inflamatoria intestinal es el principal factor de riesgo del desarrollo de esteatosis hepática metabólica por encima de las propias complicaciones metabólicas. Y esto se ve en esta diapositiva con mucha claridad. Fijaros que en nuestra corte la prevalencia de MAFLD era claramente mayor que en la corte general, como ya hemos dicho, pero quizás lo más importante es que habiendo menos prevalencia de obesidad, menos prevalencia de diabetes mellitus, y que en la población general la probabilidad de tener una fibrosis hepática avanzada era realmente mayor. Y se asociaba con una enfermedad de Crohn más frecuentemente que con una colitis ulcerosa, con una enfermedad inflamatoria intestinal más frecuentemente complicada que si no estaba complicada, y sí, la adiposidad jugaba un papel, pero un papel, como veis, claramente menor que la propia enfermedad inflamatoria. Es decir, da la impresión que estas enfermedades inflamatorias inmunomediadas son una causa de trastorno metabólico hepático, es decir, una enfermedad hepática metabólica inmunomediada. Es un concepto muy interesante. Y sobre este concepto trabajamos para ver si éramos capaces de encontrar algún patrón molecular que explicara por qué los pacientes con enfermedades inmunomediadas tenían una enfermedad metabólica, incluso hepática, incluso cuando no se asociaba a datos metabólicos convencionales, obesidad, diabetes, dislipemia, etc. Bueno, y hicimos un estudio también muy amplio de todos los pacientes entre las clínicas en los hospitales de Madrid, de Valdecilla y de Puerta de Hierro, y aquí sí juntamos todos los pacientes con enfermedades inmunomediadas, porque los datos, como habéis visto, eran muy similares en un grupo y en otro, y lo que hicimos fue un análisis similar al que os he mostrado anteriormente, y nuevamente vimos que en aquellos enfermos que tenían una enfermedad inmunomediata, y ya nos daba igual el tipo, enfermedad inflamatoria intestinal, psoriasis, hidradenitis o espondilitis anquilosante axial, la probabilidad de tener MAFLD era claramente mayor, y además de ser claramente mayor, era muy especialmente mayor la probabilidad de tener una fibrosis hepática avanzada. Esto se ve muy bien en este gráfico, como cuando hablamos de enfermedad hepática por depósito de grasa global, la prevalencia de fibrosis avanzada es mayor. Esta diferencia se hace más grande cuando no excluimos a los diabéticos, se hace mayor si excluimos a los obesos, y es extraordinariamente elevada cuando excluimos a diabéticos y a obesos. Bueno, nosotros quisimos profundizar y para ello hicimos una biopsia hepática de muestras de tejido hepático que teníamos de aproximadamente 100 pacientes, y hicimos un análisis transcriptómico de estas biopsias hepáticas, y aquí se ve el mapa de calor, es decir, se ven las diferencias en la expresión de los genes, de algunos de los principales genes, en pacientes con IMID versus a pacientes con una MASLD no ligada al IMID. Y vimos algunas diferencias, ¿no? En los pacientes con una MASLD ligado a IMID parece que hay una expresión enriquecida de vías que tienen que ver con actividad protumoral. No nos extraña. Recordad que la esteatosis hepática metabólica es capaz de producir cáncer sin tener una cirrosis hepática. Parece que hay un incremento también de la expresión de algunos genes relacionados con el control del ciclo celular. Y por el contrario, hay una downregulation de las vías relacionadas con los circuitos de recompensa, como la dopamina o algunos circuitos relacionados con la metalothianina. Esto nos daría para una discusión muy interesante, lo de la downregulation de los receptores de los circuitos de recompensa, porque esto explicaría por qué algunos pacientes que tienen enfermedades inmunomediadas tienen también un incremento de la posibilidad de tener obesidad. Bueno, y con todo esto, pues nosotros hicimos una teoría en la cual probablemente lo que nos lleva, probablemente lo que pensamos es que en los pacientes con una esteatosis hepática metabólica que tienen un IMID, las vías para llegar a esta enfermedad son doble. Por un lado, el propio trastorno metabólico y por otro, el trastorno inmunomediado. Y eso hace que esta sinergia de factores metabólicos e inmunomediados hace que la probabilidad de tener una fibrosis avanzada sea más alta. Quizás en esta diapositiva se expresa mejor cómo los índices indirectos de fibrosis son claramente más altos en la población con patología inmunomediada. Por lo tanto, y como resumen de esta parte de enfermedad inflamatoria intestinal, la esteatosis hepática metabólica es más frecuente en los pacientes con enfermedad inflamatoria intestinal que en la población general. Es, sin duda, la enfermedad hepática más frecuente en los pacientes con IBD, y hay muchas manifestaciones hepáticas, como sabemos. Es, en ocasiones, totalmente independiente de factores metabólicos, pero cuando coexisten los factores metabólicos y los factores inmunomediados, el daño es más grave. Y finalmente, recordad que, en nuestra opinión, en todos los pacientes con enfermedad inflamatoria intestinal, debemos hacer un despistaje activo de esteatosis hepática metabólica. Ya voy acabando y ahora damos una vuelta a la tortilla y ya no vamos a hablar de enfermedades inmunomediadas, sino de fenómenos inmunomediados en el contexto de MASLD. Y para ello voy a mencionar un único trabajo que se dirigido por el Clínic de Barcelona y el que nosotros tuvimos la suerte de participar. Un trabajo amplio que incluye 460 pacientes que tienen una enfermedad hepática metabólica, en los que se disponía de una biopsia hepática para un análisis histológico centralizado de esa biopsia hepática. Como veis, son pacientes que en su conjunto tenían una carga metabólica muy alta, porque el índice de masa corporal medio era de 33 y tenían un 58% tenían diabetes tipo 2. No nos extraña esta prevalencia. Se hizo un análisis histológico centralizado en el que se investigó de forma muy proactiva la posible existencia de una hepatitis autoinmune asociada a la esteatosis hepática metabólica, y se vieron algunas cosas, ¿no? Por ejemplo, se vieron que casi una cuarta parte de los pacientes con MASLD tenían autoanticuerpos circulantes, fundamentalmente anticuerpos antinucleares o anticuerpos frente al músculo liso, que la correlación con la existencia de una posible hepatitis autoinmune asociada era baja, porque estos datos sugestivos de hepatitis autoinmune se observaban en menos del 8% de los pacientes, es decir, había poca correlación. Lo que sí había era una correlación con lo que creíamos que los anticuerpos lo que denotaban era un incremento de la inflamación crónica de bajo grado que tienen estos pacientes con MASLD en la inmensa mayoría de los casos, y que probablemente está relacionado con esa inflamación adipocitaria que tienen estos enfermos, con la disfunción del tejido adiposo, y que probablemente esa era una correlación más estrecha con los anticuerpos que la posible enfermedad hepática autoinmune. Y hay un aspecto muy importante, y es que desde el punto de vista clínico tiene mucho interés, y es que aquellos pacientes en los cuales se observaban anticuerpos antinucleares o anticuerpos antimúsculo liso, la progresión a CACLD, a descompensación hepática o a muerte era claramente mayor en los pacientes que presentaban estos anticuerpos que en los que no lo presentaban. Y de una forma similar, también la probabilidad de tener un evento mayor, la muerte, que es el evento mayor que podemos tener, claramente se asociaba a la presencia de estos anticuerpos, aunque en la histología los datos de potencial hepatitis autoinmune no eran definitivos. Yo creo que esta es mi última diapositiva. Me habéis pedido, me pidió el doctor Andrade que hablara de de esteatosis hepática metabólica en las enfermedades inmunomediadas, y yo no puedo concluir que más el día es una enfermedad inmunomediada, pero sí que tiene cierto componente inmunomediado. Claramente en las enfermedades inmunomediadas, artritis reumatoide, psoriasis, hemos revisado mucho la psoriasis, la hidradenitis supurativa, Crohn, colitis ulcerosa y marginalmente espondilitis anquilosante, tienen un claro incremento de la esteatosis hepática metabólica. Este incremento de la esteatosis hepática metabólica es en muchos casos independiente de la presencia de factores de riesgo metabólicos, especialmente de obesidad. Hemos visto de forma inequívoca que la convergencia de factores metabólicos y factores inmunomediados incide en un incremento de la gravedad de la enfermedad hepática, expresada por una mayor prevalencia de fibrosis avanzada, que probablemente la enfermedad que más carga metabólica de esteatosis hepática metabólica es aquella que tiene más carga inflamatoria. Este es un aspecto que nos obligará a estar atentos en el futuro. Y finalmente, quizás tenemos que pensar que al igual que hacemos en los pacientes que viven con obesidad, en los pacientes que tienen diabetes tipo 2, en los que hemos recomendado hacer un cribado sistemático de esteatosis hepática metabólica en estos pacientes, probablemente el subgrupo de enfermos con enfermedad inmunomediada también son un subgrupo en el que tenemos que hacer un cribado sistemático de esteatosis hepática metabólica. Muchísimas gracias por permitirme estar con vosotros, aunque sea en la distancia, y estoy seguro de que el curso será un éxito. Muchas gracias.
Muchas gracias, Javier, por esta charla tan excelente. ¿Alguna pregunta en la sala?
No está online.
Ah, no está. Vale, pensaba que... Vale. Bueno, pues entonces...
Bueno, pasamos entonces a
la siguiente.
La siguiente charla, titulada Tratamiento actual de la enfermedad hepática metabólica, correrá a cargo del doctor Juan Pericás, hepatólogo del Hospital Valero de Barcelona.
Muchísimas gracias, buenas tardes. 4 aclaraciones antes de empezar con mi charla. First, I'm going to deliver it in English. Second, I'm going to focus on non-cirrhotic muscle D, although I will try to add some other comments for cirrhosis at some point. Otherwise, if we have some spare minutes, we can discuss cirrhosis in more detail. Third, I'm going to focus on pharmacological treatment rather than non-drug approaches. And that's it. Let's go for it. These are my colleagues, and this is my agenda for today. First, I'm going to try to stress some of the pathophysiological bases that have led to what is considered to be the basic pathways to the drug pipeline in muscle MASH. Secondly, what's approved nowadays in Europe and United States, what's in the pipeline that might seem promising. And then the most important part of my talk, I think, it's how do we use non-invasive tests to indicate treatment now that we have drugs or they're coming shortly. Ahora. Okay, gracias. I mean, we are used to approach chronic liver disease in terms of fibrosis. So fibrosis is problematic in muscle D, and believe it or not, because we tend to be quite linear in this regard. No funciona, ¿eh? Perdonad, no funciona. Gracias. So even if we might consider the liver a tridimensional heterogeneous organ that is not homogeneously affected throughout the slow progressive disease, which muscle decharacterizes, we tend to be quite fibrocentric. Namely, we have used a liver biopsy to design and analyze the data coming from clinical trials. And now we're using NITs basically to identify fibrosis rather than predict liver-related events, which are ultimately what matters to the patients and us as clinicians. So we need to answer, while we analyze the data that we have already available from clinical trials, fibrosis and where else? When it's too late to start treatment and too early? And is the liver the sole target of therapy? So this design from Esser, I use it always because I think it really portrays beautifully how the disease advances heterogeneously, particularly when it arrives to the cacal D cirrhosis stage. But in any case, it is reversible at potentially all stages, even cirrhosis. And secondly, it allows us to identify the correlates from histology and clinically. From reducing fat is important only relatively, but it might allow us, if we intervene in the early phases, mostly with non-pharmacological treatment, to reduce the metabolic comorbidity and the cardiometabolic risk. Steatohepatitis is important because it contributes to the disease progression, and so deterring fibrosis progression and cardiometabolic events is part of the equation. And fibrosis is the key determinant of liver-related events and also cardiometabolic events. And we could add the control and reduction of portal hypertension for cirrhotic patients. So Frank Take and colleagues put together this scheme, which is beautiful, and it highlights the hepatocyte at the center as well as the macrophage, because he's a lover of macrophages, but it's really a key cell in inflammatory control in muscle D. I would add also liver sinusoid endothelial cells, which are not only important only for cirrhosis and portal hypertension, but also in earlier phases of the disease. But in any case, we have these main mechanisms that might be summarized in antifibrotic, either direct or indirect, and control inflammation at different levels. And these are the salient families that have been used in clinical trials and have arrived to promising results. Incretins, GLP-1s and others. So selective beta THR mimetics, PPR agonists, either selective or pan-PPR, such as lanifibranor, I will discuss, and FGF, so fibroblast growth factor 21 and 19 as well, analogs. So the only drugs that we have conditionally approved, so this means that they still need final approval with liver-related events, robust data, are resmetirom and semaglutide, and they were already included in the guidelines. So we start with the basic. The basics are weight loss, even if, as you can see here, the patient is not has not obesity, and different recommendations and nuances regarding whether they are cirrhotics or not, Mediterranean diet without alcohol, because you know that Mediterranean diet usually includes wine. And then the 2024 guidelines already include resmetirom when available for F2, F3 fibrosis, and semaglutide for treating comorbidities, and semaglutide has already been approved by the FDA last year in August, and now it's been under evaluation. It's about to be approved in Europe as well. So the problem with that is that we have focused our efforts on reducing a surrogate endpoint, which is liver biopsy, combining MASH, which is steatosis, inflammation, ballooning, and fibrosis. So what is the parallel in terms of clinical events? We don't know yet, because we are still waiting for the final results of long trials, but Professor Castera has already told us about the importance of correlating dynamic FibroScan or other NITs with the likelihood of liver events. And we have done this thus far in clinical trials. NITs have been used as surrogate endpoints. We have high quality data, but this is being analyzed post hoc. For instance, the anticipate NASH is being analyzed in the Madrigal trials for resmetirom, including the cirrhotic trials. And I will show you data on that. But this has not yet been used to design the trials. FDA shows signs of openness, but not yet to include that as a final endpoint in non-cirrhotic MASH, particularly. And NITs such as Anticipate and others have been used to pre-identify patients for clinical trials. And another point which is important is that although many trials have been using AI software to support central reading, because you know that there's a lot of variability in between readers, between pathologists analyzing data, and between samples. So liver biopsy in MASH trials has been also always a source of issues in terms of analyzing endpoints. However, AI softwares have not yet been adopted by regulatory authorities as final endpoints. And I will show you a case that is problematic in that regard. So the most important recent trial that end up having good results but not leading to a success in terms of approval of the drug was the one with obesogolic acids, farnesoid receptor agonist, that end up in phase 3 showing reduction of fibrosis, but because of different issues, was not approved by FDA. And the first one that we had, based on this study, the Maestro-NASH trial, the interim analysis in 2024 showed both reduction of fibrosis and steatohepatitis with both doses of 80 and 100 milligrams. So this led to the approval by FDA and ultimately to the approval by EMA. It also importantly showed important reductions in cardiovascular related endpoints such as LDL, which as you know is a very well-established cardiovascular endpoint, and lipoprotein A. Secondary endpoints with NITs. In the upper part, you can see the relationship between FIB4 and liver biopsy at baseline, and here, which is the important point, with FibroScan. This is important because when we decide how to identify patients that should or could be potentially treated with resmetirom, we need to use NITs, and FibroScan, which is a good tool, show that 79% of patients with a FibroScan over 15% were cirrhotic, and 17% of cirrhotic were between 10 and 15 kilopascals in this study. And ELF, 54% of them had what is considered the threshold for cirrhosis, when over 11.3 when more than 20 kilopascals. So the correlation is not perfect. This is known, but with data from clinical trials, it's important to know what we are trying to treat or not. So Madrigal has not only the Maestro trial ongoing, but others, including the cirrhotic. So the sub-analysis from the Maestro NAFLD trial based on cirrhotic population showed a significant reduction on FibroScan, on KPAs, on liver stiffness at 2 years, both at 1 and 2 years, and an improvement of more than 25% change in more than half of patients. This, when compared to follow-up biopsies, showed that 35% of patients showed not only the reduction in this liver stiffness, but regression from F4 to F3. And they also analyzed, based on Bavino criteria, not in the Anticipate exactly, the changes on potential or likely and definite clinically significant portal hypertension over time. Of course, if liver stiffness improves and you are using tools that are based on liver stiffness, clinically significant portal hypertension likeliness is reduced. So more dynamic and adjust tools are probably necessary, but this analysis already exists but has not yet been presented in a conference based on Anticipate and other tools. So semaglutide, the other approved drug in the US and shortly in Europe, also show in the Essence trials significant reduction of liver fibrosis and steatohepatitis at week 72, and this led to its approval. And regarding secondary analysis, NITs, as you can see, FAST showed a good correlation with the resolution of steatohepatitis. This is important because we are lacking good tools, non-invasive tools that allow us to identify patients at the risk of MASH with steatohepatitis. Steatohepatitis, you know, it's a histological diagnosis. So even though there's promising data coming from Litmus and other prospective studies, we still don't have widely available tools to identify those patients with steatohepatitis. And similar to the Madrigal trial, the reductions in both BCT, LSM, and ELF were present in responders compared to non-responders, as well as those receiving placebo in similar proportions. So let's go to the pipeline. The first family, incretins. You know that there's a wealth of different combinations targeting incretin receptors. Tirzepatide was an example. This was presented 2 years ago in the EASL in Amsterdam, showing good reduction in significant reduction in fibrosis and steatohepatitis. So the dose of 15 milligrams was chosen for the phase 3 study. Is the synergy outcomes that is targeting advanced fibrosis and CACLD, and is combined with retatrutide, which is a triple agonist. That not only targets GLP-1 and glucagon receptor, but also GIP receptors agonist. And there are 2 different arms in this non-invasive based trial, which is important in terms of design. Survodutide is a double agonist combining GLP-1 with glucagon receptor. The phase 2b showed good results in non-cirrhotic MASH, and a phase 1 trial also showed good results in cirrhosis. So the combined program Leverage is now ongoing for both non-fibrotic and non-cirrhotic and cirrhotic trial. Efinopegdutide combining again GLP-1 with glucagon receptor. The phase 2A earlier with non-invasive data coming from MRI, PDFF, as well as body weight and transaminases on led to the program with non-cirrhotic and cirrhotic patients that is being finalized. The recruitment for the 13 trials already finalized. The 17 has already closed, and the analyses are coming shortly. Altimmune conducted this study with pemvidutide, again a double agonist with GLP-1 and GCR, and this has not yet led to the phase 3. I don't know, perhaps you are aware of this trial going on again, but I haven't seen the registry in clinicaltrials.gov, and so I think it has not yet started at the global level. Lanifibranor is a pan-PPR agonist, so it targets alpha, beta, gamma receptors, and in the phase 2 trial showed not only reduction of fibrosis and NASH, but they also found significant reduction in the composite endpoint, both at the same time, which is important because what we want is that patients improve in both regards, primarily in fibrosis, but not only. So the NATIVE3 or the NATIVE trial, it's a French company. It's also underway and almost about to be completed. Pegozafermin is another FGF21 agonist that has shown in phase 2 good results, and that moved to the phase 3 is being completed yet for both non-cirrhotic and cirrhotic trials. This started as a small company, 89 Bio, that was recently acquired by Roche, and a similar history with the efimosfermin, which is a long-acting, started by Boston and then acquired for GSK, now moving to the phase 3, the Nebula program, combining non-cirrhotic and cirrhotic trials. And the Akero history is similar, but this has a nuance, a specific detail, good results in phase 2 for non-cirrhotic, but also for the first time showing reduction in fibrosis or cirrhosis regression in liver biopsy at 96 weeks. So that's why I have included this in particular. So in combination, this led to the Synchrony program that is underway as well. This combines, importantly, the FGF agonist with GLP-1. A different family, the oral fatty acid synthetase denifanstat, in phase 2b showed good results. So the Fascinate trial is ongoing globally. Spain was not included as a recruiting country. And the only combination beyond GLP-1 with FGF21 agonist is this one. It's a collaboration between Gilead and Novo Nordisk, including Silofex or Firsocastat and semaglutide, that did not end up showing reduction in the primary endpoint of fibrosis improvement. However, the PathAI analysis, so the AI-assisted or supported analysis, did show an improvement. So this is the discussion that is ongoing nowadays. So would FDA be open to a phase 3 based on PathAI-based results? Probably not. But so how to indicate and monitor treatment in clinical practice? The first glimpse we had was this expert position paper coming from the US just after the resmetirom was approved there. So they proposed to treat those patients with BCT between 10 and 20 and ELF between 9.2 and 9.7. I'm going to stick to FibroScan and ELF because they're the more widely available, and not treating those that might have cirrhosis based on FibroScan over 20 and ELF over 11.3. Then the ASLD position statement together with this led to these new recommendations, which are quite similar, but they put a lower threshold for treating between 8 and 15, ELF between 9.2 and 10.4, and you could also treat those patients until 20 in terms of FibroScan or 11, but rather with caution. So prioritize the green light patients. That was the main result. When we analyzed this criteria in the Spanish registry in EPAMED, what we found is that, at least in our cohort, which this might be, this might vary because one thing is a biopsy-based cohort. It's the percentages of metabolic comorbidities differ widely from the United States and so on and so forth. But however, in any case, the percentage of patients that may have F2 or F3 in our cohort were, as you can see, less than 50%. Whereas using what we proposed, which was first step, FIB4, and then combined with metabolic comorbidities, the most important ones, type 2 diabetes, overweight or obesity, and then the second step, FibroScan between 8 and 25, the percentage increased with a low proportion of cirrhotics and a low proportion of patients not treated because not being identified. Is this perfect? No. And this is fresh from the oven. This was published online 10 days ago, and is the global initiative from the NASH Council. There's been also guidelines coming from Germany, where resmetirom is already approved, and Italy. But this is important because beyond the thresholds for FibroScan and ELF, which are essentially the same I have just explained, what they tackle is the fact that for treatment-naive patients and type 2 diabetes and obesity, they have recommended semaglutide as a preferred treatment rather than resmetirom. The follow-up for this treatment is adjusted to the length of the clinical trials for these respective drugs. So 48 weeks for resmetirom, 72 weeks for semaglutide, and they have put together very clear stopping rules. So what's improvement, what's progression, and what's worsening, and when the drug should be stopped. So it was taking a look. And real-world data from the United States based on resmetirom show that around 16% of patients that have been included thus far, this is based on around 700 patients, so it's not massive data, did not fulfill the basic FibroScan criteria, and that liver stiffness, even though with short follow-up, seemed to improve globally. Also, basic things, 57% of patients had more than 3 comorbidities, 42% were already treated with GLP-1s at baseline, but note that only 34% of patients had follow-up beyond 6 months. 9% discontinued treatment during this period, and 204, so around 40% were concomitantly treated with GLP-1s. And this is just a note of caution from a combined cohort from Paris with blood ratio, Alessandra Mangia from Bari, and our cohort in Vallebron, where we have found that the accuracy of these general criteria really varies depending on the presence of obesity and type 2 diabetes, which is common sense, of course, but we have not used this. So I think that there are two pieces missing in the guidance: how to adapt the guidance specifically to metabolic comorbidities, and how to use dynamic NITs over time. We have already the first drugs here. We still need combination therapies. The pipeline has adjusted swiftly. There are available treatments that will change the landscape of health systems, of course, how we screen and refer these patients, how we assess fibrosis, and how we initiate and follow up treatment. But we still need to improve some NITs to indicate and monitor treatment. Thank you for your attention.
¿Alguna pregunta?
¿Dónde se toma la cerveza, no?
These guidelines, international guidelines, what are they based on? You know, in UK, nothing will pass unless cost-effectiveness analysis is really done. And I do know that cost-effectiveness analysis in US has been done, but they have not really determined the license, but it does still determine the choice. Okay, I know tirzepatide, all the drugs, semaglutide, all of them have gone on, and you show me UNOSIS guidelines now for international population. What is it based on?
I think I'm going to skip that question because you have an author just sitting behind you. So no. Just one clarification.
Then just tell me that, well, in Spain, is there anybody who like NICE will kind of come up with some more independent analysis to recommend these?
Yeah, I mean, these are surely necessary. Of course, the problem here is that there's the leap from biopsy to non-invasive treatment, and some recommendations should be put together once national regulatory authorities approve the drug, because clinicians should know how to treat. But then we need periodic updates based on, as you say, cost-effective analysis. I know that in the US, the ASLD is doing a periodic analysis, I think, every 6 months based on this, and the recommendation might change slightly based on what they found based on real-world data. The Global Council, I don't know. Laurent will know better.
Just to answer your question, there's not a guideline endorsed by a society. They're just recommendation by a bunch of experts, and after a Delphi process, we step around. So it's just guidance. It's not guideline.
You know, basically, this is the risk of guidance. You see, people just read the headlines. They don't read what the evidence is based on, and they make their own individualization. So they can be counterproductive. And I'm telling it seriously because NICE offers a guideline with a consistent basis. But pressure on drawing a guideline itself varies depending upon whether it's a cancer or not, whether somebody is really pushing it for or not, you see. So there's a paper in Lancet, which was published last year, which showed that NICE guidance has drifted despite it has gone the same criteria, eventually cost-adjusted life years for the population. Because if you kind of give a guidance based on 30,000 life years saved for a 2 months benefit from a cancer drug, it costs more to overall population. These are opportunity costs. We never really count it. So there is a risk of all these guidance.
I fully agree with you. But
there's a publication for you.
There's an article in The Guardian today about anti-amyloid drugs for Alzheimer, based on a Cochrane review that have shown that the 7 drugs, including the 2 that have been approved in the UK for a long time, do not work. So all is post-hoc. So the cost is already done. But you don't have cost-effectiveness data to approve drugs in a particular country. I don't. This is the hen and the egg problem. I don't know how to. Go ahead, please.
Thank you. Very nice presentation. I agree completely with Guru. I mean, it's important to base the guidelines on evaluation by people who are not involved with the pharmaceutical companies. Because those who write the guidelines, they are often doing these clinical trials and speaker bureaus and everything. But one question, this was the comment. Do you know the use of respiratory in Europe until now?
Yeah, I mean, it was approved in Germany 6 months ago, 6 months ago. So there's nothing published. I know that it's very heterogeneous, quite concentrated in Berlin and other large centers, but it's not widely spread.
How many prescriptions have you done?
Have I done?
Yeah.
None, because I'm Spanish. I work here. In Spain, it's supposed to be approved by the end of the year. But
so let me add a comment to your question. For France, we now have a conditional approval, but it's for F3 patients only, like 6 weeks ago. And to my knowledge, no patient has been treated yet. So it's not going to be a tsunami for sure. So my question, of course, is regarding NIT, because this is now the standard for selecting patients. So I have 2 questions. How do you reconcile this discrepancy between the expert recommendation, with, as it's been acknowledged, have a lot of conflict of interest with the company, and the ACLD guidance, which is basically the same in terms of conflict of interest, but not in the term of cutoff? Second point is, now we're supposed also to assess response with NITs. But if you look at the level of evidence, is very, 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 very low. So how are we going to proceed in our practice next Monday?
Yeah. No, I don't have compelling answers to your comments.
But
I mean,
8 and 10, what are you going to do? Once you have resmetirom, where do you draw the line? Do you think it's reasonable to treat with 8 kilopascal?
No. Probably draw the line in 12, between 10 and 12, and probably higher in the higher end of the spectrum, from 12 to 20 probably. But it depends on how do you pre-select the patient. So if the metabolic burden is high, you could probably go for narrower.
So if I may just comment, at the end of the day, what's going to make the difference are the payers, as usual. And I just had a look, and I think I will show this data at EASL next month. If you choose between 8 and 10, how many patients? So in primary care and in a liver clinic, basically you double the number of patients. So for instance, in the liver screen cohort, it would go from 2 to 4% of patients qualifying for treatment, which is a lot, and the payer are not going to like it. And to your point, where you've shown this nice study, to my knowledge, this is the only study published in CGH on real-life cohorts. We have very similar data, as you've shown. You're not capturing all the patients with the NITs, either with 8 or 10, but of course, if you go to 8, you increase the number.
Yeah, I agree with you that the payer would draw the line where they want us to stop. And the other discussions whether just go for F3 first and then...
Yeah, this is what was recommended in France. Yeah.
Ok, si no hay más preguntas, yo creo que ya estamos también fuera de tiempo. Damos por concluida esta primera jornada. Creo que ha sido una jornada extremadamente interesante. Me gustaría agradecer a todos los ponentes y a los que habéis asistido vuestra participación. Ha sido un éxito y no olvidéis que mañana empezamos a las 9. A las 9 en punto. Por favor, no lleguéis tarde para que podamos desarrollar la jornada con normalidad.